Now our next speaker is Dr. Scott Mcnally from University of Utah. He will present clinical application of vessel wall imaging.
Thank you very much for the invitation. I'll be talking about clinical applications of vessel wall imaging. We'll begin by talking about extracranial disease, move on to intracranial disease and some other applications. And the goal of this is to better identify and characterize vascular pathology and basically improve patient care. I will put some data in this talk, but the images from the patients that you see are the ones that in particular change the mind of neurologists and neurosurgeons in the use of vessel wall imaging. So as you know, carotid plaque early on was heavily dependent on stenosis. That was the only marker that we could image and was used to determine both stroke etiology and treatment. The main problem with stenosis, one big problem, is that stroke risk begins to decrease when near occlusion is reached. Another problem is that stroke can occur from non-stenotic vessels. In this case illustrates that. This was a patient that came in with recurrent events to the right ICA territory. You can see high signal and diffusion weighted imaging coupled with more remote infarcts in the same territory. This patient had renal failure, and so instead of getting a CTA, got an MRA, which showed very mild stenosis. So this was about a 25% stenosis by an acid. When we looked at this in cross-section, you could see there was a very large plaque, hyperintense on T1 weighted sequences like time of flight and impure age. And in this case, we could tell the treating clinicians that this was intraplaque hemorrhage. And now we know that plaque hemorrhage leads to both plaque progression and embolization as well as progression of stenosis. More often we see this in large carotid plaques, much more rarely intracranially. And this for us was the first case at the University of Utah that really the surgeons went to surgery when the patient did not have a severe or significant stenosis. This stenosis wasn't even 50%. But they did that based on the recurrent strokes and the intraplaque hemorrhage that we saw in this sequence. So they started to buy into that at that time. Now we use the MPRH sequence primarily at the University of Utah. We use a signal threshold of twofold signal intensity over adjacent sternocleidomastoid muscle. Other sequences can be used, like SNAP, which was developed at the University of Washington with Trenwan's group, and time of flight signal has also been used. Based on early meta-analyses in 2013, Hosseini's meta-analysis was cut off here. We now know that symptomatic intraplaque hemorrhage is highly predictive of future stroke. It has between a 15 to 45% annual stroke risk with high hazard ratios. And what we see here is when you image patients and they come in with their first symptoms and they happen to have intraplaque hemorrhage, those are the patients that are going to have the recurrent stroke risk in both moderate and severe stenosis categories. Other plaque components that we can image include lipid-rich necrotic core, which is mildly T1 hyperintense, but is characteristically low signal on MPRH and time of flight. This, as was shown earlier, is non-enhancing, as you can see in this figure here, coupled with this very low signal calcification. Lipid-rich necrotic core also has an increased hazard ratio for future stroke, though when you look at IPH negative lipid-rich necrotic core, at least one study showed that this may have a lower stroke risk. Thin and ruptured fibrous cap can also be imaged with MR. We do not routinely image that for clinical patients, but if you see a thin and ruptured fibrous cap, that also has a high hazard ratio for future stroke. And again, this study did not discriminate between plaque hemorrhage positive and negative thin and ruptured fibrous cap. So we adapted MPRH to our clinical protocols. We found that it could also detect dissection. It outperformed not only time of flight, but T1 fat sat, standard T1 fat sat sequences with a higher kappa, about 0.83 compared to 0.58. Also, MPRH detected intramural hematoma was independently associated with territorial infarct, in addition to some other factors with dissection, as you can see in this case. One question we had early on is we perform a lot more CTAs than MRIs, and can you use CTA markers to detect plaque hemorrhage? One of the earlier studies suggested that ulceration could be a surrogate marker, but then further research showed that you could get intraplaque hemorrhage with increased stenosis, age, and just being male. So we took a look at this with a few hundred patients that underwent both CTA and MRI with Dr. Laura Eisenmenger. We looked at things like stenosis, plaque thickness, ulceration, intraliminal thrombus, tried to figure out what predicted intraplaque hemorrhage the best. We also included some calcification patterns, and one of these was a rim sign, which we called if there was a thin rim of peripheral calcification coupled with at least 2 millimeters of soft plaque deep to that. What we found was that, yes, the rim sign was predictive of intraplaque hemorrhage along with increasing plaque thickness, so the thicker the plaque and the presence of a rim sign was highly predictive of intraplaque hemorrhage, and this outperformed what was previously thought to be a surrogate marker, that being ulceration or stenosis, which we use clinically. We went a step further and looked at which CTA markers are predictive of stroke. As you know, neurologists and neurosurgeons in the United States primarily use stenosis based on NASIC cutoffs of 50 and 70%. Instead of stenosis, we found the intraliminal thrombus, the smoking gun that you heard talked about earlier, was highly predictive of stroke, though fairly rare in our population. But in addition to that, rim sign and maximum soft plaque thickness were in our final model for predicting stroke. So this was all well and good. Our neurologists and neurosurgeons seemed to buy into the intraplaque hemorrhage imaging as well as the use of MPRH for dissection. But really, to detect stroke etiology, you need full workup through the aortic arch, through the circle of Willis. And it took some time to get people to buy in to intracranial vessel wall MRI, at least clinically, at our institution. But this case in particular changed a lot of minds at our weekly neurovascular conference. So this was an older patient. She had atherosclerosis risk factors, including hyperlipidemia, hypertension, but she also had a history of lymphoma. She was treated with chemotherapy, and she came in with a left lenticular striate distribution infarct. On CTA, we saw this rim sign, and we thought, oh, this would be a great patient for our study. We recruited her to get a preoperative MRI. She was going to go to endarterectomy based off of this. And we were patting ourselves on the back. Yes, she's got intraplaque hemorrhage. But one of our fellow radiologists said, hey, put on the brakes. This patient has some intracranial disease that you may want to take a look at. And Adam de Havilland, who was a neurologist who had just come from University of Washington, he talked a lot about Mahmoud's work and Trun's work, looking at intracranial vessel wall enhancement. And so we tacked that on to her research study and found, lo and behold, she had very avid circumferential wall enhancement along her M1 and A1 segments. On further history, she had a facial rash a few months ago. She was treated empirically for VZV and was thought to have cleared it. However, when they did an LP, she was still PCR positive. So the thought was we'd treat her with a cyclovir and then have her come back in a month or so, and then she would get her endarterectomy. The problem was her enhancement worsened, as did her narrowing, and this continued to worsen, as you can see on this angiogram. She began to have more infarcts, and eventually, even though she retained, we kept treating her with acyclovir, her VCV PCR remained positive despite treatment, and she ended up dying. So this was a case of intracranial vasculitis. Characteristically, we use this as clinicians. It should have no T2 signal. It should have concentric enhancement like this case. We often treat with steroids and antivirals. This is another case of a young patient, however, does have atherosclerosis risk factors. He came in with acute right ICA distribution infarcts and a very focal right M1 stenosis. You can see that on angiogram. This appears more shelf-like. On T1 post-contrast imaging, there's a very focal enhancement, and we often have to do reformats to get the best image here. So this is a coronal oblique reformat that shows that this enhancement is eccentric. It's primarily affecting the inferior margin of the M1. Same thing with the T2 space. It's very difficult to see on the axial sometimes, so you have to do reformat. And this, there is T2 signal in this region, so this indicates atherosclerotic plaque. It should be eccentric, high T2 signal, and often enhancement indicates high risk. This, in our experience, can be present without carotid disease, and our neurologists treat this with maximum medical therapy. Here's another typical case that may go to vessel wall imaging at our institution. A young female after delivery of her first child presents with subarachnoid hemorrhage and a focal infarct. This patient had multivessel narrowing on angiogram. This was also seen on time of flight MIP. This doesn't show up very well, but there was no T2 signal in the wall. And on post-contrast imaging, unlike the other cases, there is no wall enhancement in these vessels. So this was RCVS. Vasospasm appears similar. This should have no T2 signal, no enhancement. These patients are often treated with calcium channel blockers and removal of the inciting agent. So we use these rules, the T2 signal, the enhancement, to kind of tell us which kind of disease process is present. However, there is overlap. Most of the time, we only see T2 signal in plaque, though we have seen vasculitis with T2 signal, especially chronic or recurrent bouts of vasculitis. RCVS should not enhance, but rarely we have seen it enhance, especially in cases of recurrent RCVS. I'll spend the rest of the time going over some cases and other uses of vessel wall MR that we've seen and used. Early on in 2013, this pilot study showed you could use vessel wall MR to predict which aneurysm was the aneurysm that ruptured in patients presenting with subarachnoid hemorrhage and multiple aneurysms. Multiple additional single-center trials have shown that vessel wall enhancement is predictive of unstable aneurysms, and this was summarized in a recent meta-analysis in 2022, so this is important. We've used this. This case really allowed our neurosurgeons to buy into this imaging. This patient was found down, had a hemorrhage, both parenchymal and subarachnoid, had some irregularity of their ICA that was seen on CTA, and so the thought was to go to vessel wall MR in the morning. So within a few hours, you can see that this, on time of flight, this was indeed an aneurysm. It grew. In addition to that, there was wall enhancement along the anterior wall there. So this was a dangerous dorsal variant ICA pseudoaneurysm. And you can see that on the follow-up angiogram. So this was treated after that. This was another problematic case, a diabetic female you'd think would have atherosclerosis presenting with rapid cognitive decline. Her angiogram showed kind of smooth narrowing in multiple vessels, including the basilar tip and the branches. This patient went on to vessel wall MR. You can see that on the time of flight. But unexpectedly, there was a lot of low T2 signal material on the T2 space that was not picked up on the initial standard MR, and there was also quite a lot of enhancement in the cisterns tracking along the vessels. So this turned out to be a case of coccidioides meningitis, and the vessel wall MR not only helped in diagnosis, but also treatment monitoring. This patient went on to be treated with fluconazole. And you can see on the follow-up, there was still remaining T2 signal in the cisterns and enhancement after 6 months of treatment. So this patient had to be treated for another few months until this resolved. So this was a good way to monitor treatment. In pediatric patients, we sometimes see stroke. This was a young patient that presented with a right MCA infarct. The initial angiogram was clear of a large vessel occlusion, though there was some irregularity in the carotid terminus, and there was some debate over whether or not this was due to vasculitis or the clot that was previously there. So the patient went on to vessel wall MR. This was somewhat unexpected. Instead of just seeing enhancement at the carotid terminus, we also saw enhancement in the M2 branches. And you can see that here going up the sylvian fissure. And if we go back to that angiogram real quick, we went back to it and looked at it again. You could see there were areas of narrowing that were missed on the initial angiogram when we looked at it. So this was a case of vasculitis. This patient was treated with steroids and antivirals and did well. In children, often this is called a focal arteriopathy. This case was a 69-year-old female, came in with a hemorrhage, and not only did she have the acute hemorrhage, but she had some microhemorrhages and siderosis, as well as a recent infarct. This patient had lumen imaging that was negative, but vessel wall imaging that was very positive. Not only did you see leptomeningeal enhancement, but also some enhancement tracking along the vessel walls. This patient was biopsied and turned out to have cerebral amyloid angiopathy. Sometimes this is associated with inflammation, and this was the case in this patient. Early studies suggest that leptomeningeal enhancement may be associated with ABRA and CAA-related inflammation. We found in our study with Akiko Sakata that vessel wall enhancement predicts not only concurrent ischemic strokes, but follow-up strokes, up to a 60% stroke risk in patients with wall enhancement. Another case, presumably left MCA distribution infarct, though hard to see the vessel on T2 weighted images. There was very thick enhancement on T1 post-contrast imaging. This area looked strange enough that we took another look at it on perfusion. Unexpectedly, there was high perfusion in this region. This patient turned out to have a high-grade tumor with GBM wrapping around an M1 branch. And then the last case, patient recently presented with a stroke workup, initially thought to be negative, but irregularity in the STAs confirmed to be enhancement, and a STA vasculitis biopsy just showed giant cell arteritis. So in summary, clinical uses of SOL MRI are expanding, including ischemic stroke workup, stroke without obvious source in the young, multiple potential sources, worse stenosis workup, as well as other indications such as aneurysms, perivascular tumor infection, and vasculitis extracranially. Thank you very much.